Washington State Orthopedic Association monthly REOP meeting, Regional Educational Outreach Program. Today we're going large-scale national with a strong local regional tone. And the topic is, again, following up on the IMPACT program. This is making a meaningful grassroots difference by implementing the wonderful work of our AOA, our American Orthopedic Association program towards owning the bone and making a difference to this true pandemic, which affects so many patients. I was in spine clinic today. You see my clothes. A third of my patients had literally bad, untreated osteoporosis, and that's not an exaggeration. And it's frequently very significant problems emanate from that. So our thoughts are to implement this on a grassroots level by involving ER doctors, by involving radiologists, by extending this to primary care doctors, and by using algorithmic care rather than doing what currently seems to be the case, which is largely damage control surgery, fixing the fracture and letting the patients then fend for themselves, and sometimes occasionally putting them on some medications. We have an incredible program today. I'm so deeply grateful for all of our speakers. All of them have made a significant impact. And before I go on to introduce our great guest speakers, I want to make a big shout out to Dr. Alan Greenwald, whose birthday is tonight. Happy birthday, Alan. And he chairs our IMPACT program, and he's had the idea for this, and he's extremely passionate about this. And again, we're all eager to learn from our great guest speakers from out of state and in state. The sequence in the lineup couldn't be any better. It's a dream come true. So I want to shut up as soon as possible to allow our eminent speakers to articulate their visions. Professor Stephen Cates is chairman at the University of Richmond, Virginia, Richmond, and he is a national and international figure in geriatric fracture care. He's lectured here previously, and his other great specialty, which is infections. But he has made an amazing difference already with his academic journal and his seminal work with the AOA group to try to stem this tide of geriatric fracture care and take it out of this aura of undesirable fractures into a modern, algorithmic-driven and profitable for the healthcare system's prospective care. He's going to lecture about how to make a financially viable plan out of this. Dr. Doug Beal from Oklahoma is here. He's an interventionalist, and again, he and Dr. Neil Schonert together have worked very heavily on early interventions and proving that early interventions can make a very meaningful difference, again, if you apply algorithms. And my faculty mentor, Dr. Anderson from the University of Wisconsin, recently retired. We'll talk about, again, the big picture of AOA and how we can apply this, what the success statistics are, and how we can really implement that without reinventing the wheel. We have a couple of great guests on, and then the panelist bar, Mr. Steve Schwartz, and our own former fellow now at the Methodist Hospital in Houston, Jeff Fravert, who's published on opportunistic CT following the examples of Dr. Anderson. I promised to shut up, but as you can probably tell, I'm deeply conflicted about every single speaker, so my conflict of interest declaration is clear. I love all the speakers. I consider them eminent educators and difference makers. I'm so grateful that they took the time. In the case of Dr. Speetz, our lead-off speaker, it is very late for him, so let's get you shooting, Stephen. Talk to us about how we can make geriatric fracture care something that hospitals don't shy away from, but that can actually turn a reasonable margin out of it to fund their missions. Stephen, thanks for joining us.
Thanks very much, and it's an honor to be here today and speak to you. Thank you for inviting me, Dr. Chapman, and I have a little bit to share on this topic on financial planning, fracture liaison service. I do have a few disclosures. I'm journal editor, and I do chair the AOA on the Bone Committee, and I have some federal research funding. So what's covered? We are going to talk a little bit about a fracture liaison service, who's best to run it, how do you set it up, and we'll break even. So obviously the reason to do this is post-fracture treatment rates are unfortunately low. If you include any medicine, even calcium and vitamin D, it's 34%, and 24% prior to fracture, and that includes calcium and vitamin D, which are probably not really doing much. And most studies that have been published to date show really low treatment rates. This data was from the NISQIP registry in 2016 that we started on hip fractures. So osteoporosis, really, if you see a fragility fracture, that's a fall from a standing height or less, these really low energy injuries, and they fractured, they have osteoporosis, regardless of what the DEXA shows you. The DEXA certainly is a standard of care. Some people are using CT as well, but DEXA is your standard of care test. Cheap, effective, done every 2 years. The teachable moment for that patient and their family is when they break. So tell the patient their diagnosis, tell them when they have that fragility fracture, you have osteoporosis. It doesn't matter what your prior DEXA shows, you have osteoporosis, you broke, you have the end of the disease here. Remember that previous fracture increases the future fracture risk. So whether it's a hip fracture or it's a vertebral fracture, they have a tremendously higher risk of getting another fracture. So that's the patient who's most important to treat. So what's an FLS, or fracture liaison service? The fracture liaison service looks at the post-fracture bone health assessment and management. Many will get involved in referrals for falls prevention as well. It was initially founded in Glasgow, Scotland by McClellan, and it's really spread worldwide, and it's been shown to be the most effective model for managing post-fracture osteoporosis. So who's the best person to run it? These things are usually run by an APP, but can be run by a physician. Generally speaking, the APPs do very well with this. The focus is on patient education and medical management. And based on personal experience, it's most important to find the right personality or right APP to do this. If you find the right APP, your program is going to be really effective. So you do need backup support for an APP, even if they're good. And normally you have a physician or a surgeon who has some interest in bone health to support your APP in running the program. In my department, which is an academic department, we have 50 surgeons, about 25 APPs. Our program has one FLS APP, and I support her. So it's not necessary to, as a supporting physician, to meet with every patient, but occasionally you have to talk to a difficult patient. And for me, I get a lot of text messages and email messages from the APP. So how do you get started with this? Really, the first thing to do is write a short business plan. I just put a little picture of a business plan I wrote for taking a PEDS call here, but you can have a little plan like this. So really, that's about how long it is. If it's longer than that, I've learned that your hospital administrators will not read it. So I started off, I was writing these lengthy business plans. I was very pleased with myself, and the only one who ever read it was me. So the A3 plan, it's named after the A3 size piece of paper, or legal paper, shouldn't be any longer than that, and preferably a little shorter. So you want to ask how many patients are you going to serve? That's relatively easy. It's pretty much how many wrist fractures in people over 50, hip fractures, and vertebral fractures you treated. If you just add all of those up, you'll have a pretty good number. There's obviously more than that. What location is your best location, or maybe you have more than one location, or are you going to split it between one or two locations? How are the patients going to be found? So if you have a medical record like Epic or one of the other EMRs, which most people have now, you can have some sort of a finding mechanism. Either the physician says yes, they respond to a short pop-up that says yes, it's a fragility fracture, or maybe you just use an algorithm to find it from the EMR. And how do they get referred? Obviously, there should be some sort of referral order to refer to the program. And then you have to decide what services your program will actually provide. And then what volume do you actually think will show up? So that goes into your plan. So what does the FLS do? Ideally, you send the patients with a fragility fracture over 50 years of age. Maybe get DEXAs as well on these. It's often very helpful. The program can support sending people to their primary care physician, but remember, the primary care doctor has a ton of other things that they have to manage: blood pressure, cholesterol, cancer prevention, the diabetes, all sorts of other issues that they are required to manage to get their good scores and get a bonus. So in order to realistically do this, your FLS program should manage the osteoporosis for most of the patients. Lifestyle modifications, particularly if the patient has a very unhealthy lifestyle, would be helpful. Talk about falls prevention, referral to appropriate exercise classes, maybe to a dietitian as well, and facilitate the investigation and treatment. And then I think that it's ideal to collect data in a registry with an example like on the bone. So once your business plan's completed, choose the right APP for the program. The APP we have now was very dissatisfied with our neurology department, and she quit. But she knew all about medicine management. She'd been doing it in neurology, but she wanted out, so she joined us, and she's just doing a great job with this. She's perfect for this job. She likes to spend time with the patients, willing to answer phone calls and messages. You want somebody who's patient and kind. They need to be thoroughly trained so they understand all about metabolic bone health, and they have to know about basic fractures. And they also need to be able to recognize when they don't know what to do. So they should know about the medicines, the side effects, the indications for each medicine. Maybe some sort of an algorithm would be helpful. Train the APP how to read a DEXA scan. I mean, there's a proper way to read the actual DEXA scan report. I think they need one-on-one time for training the patient management. So initially I spent time directly training our APP, and then they should have the appropriate pharmaceutical sales staff support for models and kits, and some patients can't afford their medicine, so they're maybe a discount card or something like that. So will the program break even? Probably in the first year, no, but it should come close to breaking even eventually. If you include the money earned from infusions and injections, it will more than break even. You'll make money. So it depends on how your finances are structured. But if you're doing the infusions and the downstream revenues from referrals for studies, it'll more than break even. But the first year, probably not just some patient revenues. It is a public service to your community from your practice. If you're looking to meet the MIPS criteria for Medicare, it'll help you meet that. And it brings new patients into the practice for sure. I wouldn't classify it as a big money-making program unless you include the infusions and downstream. So here's a simple business plan to start out. This is a new APP, new FLS program. So background, we have a need for an FLS program at our medical center. There's no program in town. We have personnel, but no organized program. It's not good care. We'd like an organized program. So this is the sort of thing you can put in your plan. And really shouldn't be a lot longer than this, because this is all they're going to read. They're not going to read anything more than this as a hospital administrator. Also use small words. Don't use a lot of big words in it. So, we see approximately 1,000 fragility fractures a year. Very few get appropriate care. So we're recommending we start the program with existing personnel, 9 sessions a week, refer all the fragility fractures. So 9 sessions a week. The initial estimated revenues just from the patient visits, $88,000. The nurse practitioner costs more than that. So the first year net loss. However, they're ordering infusions, they're ordering advanced imaging, they're ordering DEXAs, they're ordering a variety of other things, physical therapy and falls assessments by therapy. So overall, they're going to make money for the system, but just on a straight up service, not the first year. And then you have a plan, maybe revisit it 1 year, assess the success or failure of the program. So you're revisiting the program at 1 year and redo this plan and see where you're at. So, this is sort of the summary, losing money the first year, but typically most new programs will lose the first year. The second year should be close to break even. Maintaining the program, it requires the supervisor, in this case it was me, frequent meetings with the APP, review the metrics, talk about the locations, look at the data. Are you getting a lot of business at one place but not at the other? How much time spent with each patient for new visits, return visits, and so forth? How much time is needed for administrative activities like filling out pre-authorization for the medicines? There is some effort that's needed to market to colleagues, other people in the department and in town. And the APP does need to be supported by a physician. There also needs to be a physician to refer out. So if there is an endocrinologist or a rheumatologist who's interested, and again, the endocrinologists are spending a lot of time on diabetes and thyroid disease. Most of them don't have much time to spend on bone. Rheumatologists, with all the new biologics, they're inundated with rheumatologic conditions, and that's what they really want to see. They don't want to spend a lot of time on this. So you do need someone to help them with the more complicated cases. So hyperparathyroidism, if you have a primary hyperparathyroidism, that's your high calcium, high PTH. That one's going to go to endocrinologist for workup, and then to a head and neck surgeon or endocrine surgeon to take out the bad parathyroid gland. The renal cases, you're going to probably need their dialysis doc to help you. Falls prevention, as I said, we send those to our therapists to work on falls prevention and falls training. And then, you get these pathways established, build a good rapport, and that should work pretty well. So programs that have worked, the Own the Bone program works with most places. In the closed systems like Kaiser and Geisinger, they have successful programs that have been proven to be a success and make money for the system. Resources that you can use to set up a new program. Well, join Own the Bone. We have a ton of resources that are provided to the new program. It's $2,500 to join it. It's nothing. And you get all the data, you get all the educational activities. There's monthly bone health echoes, there's webinars, we have a course, we have tons of materials. The NOF has a lot of good, National Osteoporosis Foundation's got a lot of good materials and guidance. Or there could be a one-on-one work with a colleague, so the APP could visit a nurse practitioner who's doing a great job already. As surgeons, our responsibility is identify the patient, tell them their diagnosis, tell them they need treatment, look into it whether or not they have osteoporosis, with some other underlying cause. Maybe they have a low vitamin D or hyperparathyroidism or some other issue. Chronic steroid use is a culprit. Make sure that they are referred to the FLS and follow up and educate the patient and the family. Remember, the teaching moment is when they break. That's the best time to teach them. They don't forget when you tell them that that's why they broke. So thanks very much. And Jens, do you want us to take questions at the end or now?
Let me give you one question right now. So how much can be done virtually of these interactions outside of the ER, obviously when you have an acute fracture? How much of this can be streamlined truly when you have a geographically diverse area? Our system alone here at 7 hospitals, the bigger area for Swedish/Providence is 52 hospitals. How much of this do you envision being possible in a virtual environment using parameters and standardized protocols?
Yeah, so I think a lot can be done virtually, and a lot of the follow-up can be done virtually. Obviously, things that they're going to have to do in person is get the tests, get the blood draw, and get a scan. But we do use virtual follow-ups, and certainly I think it's one good thing that COVID has shown us is that we can do things virtually. And things like this meeting, I'm in Richmond, Virginia, and we have people in other parts of the country, mostly Seattle area, and it's like we're having a reasonable meeting now. So the telehealth or these virtual visits can be useful, especially for follow-ups.
Great. More to come later. Are you okay to stay awake? I know you have 3 hours.
Yeah, I'm fine. No, I'm fine.
Awesome. You sound great.
I'm
great.
fine.
So if you're okay with it, let's move on to our next speaker, because I want to have an interactive discussion later, and I'm sure there are many other questions. So thank you, Stephen, for a outstanding work, and congratulations on your seminal work to kind of orchestrate the whole thing, so it's hopefully appealing to our administrators also. But again, we need to change the paradigm. We need to kind of start more ground roots level. Dr. Doug Beal is a radiologist by training. He has an illustrious career. He's in Oklahoma City now. In Oklahoma, he was associated with the university there. He got his MD at Georgetown. He did a further fellowship training at Mayo. He had a distinguished career in the Air Force, and he has now become a truly amazing private practice academician who's the leading investor also and owner of the Spine Fracture Institute. And he has really been instrumental in trying to change how we're dealing with acute fracture care recognition. Doug, and your big question that goes into the next speaker after that is, how does this work in terms of involving radiologists early in the recognition and improving the reporting so that these patients get actually recognized, preferably before a fracture happens, in being at-risk fracture patients. So thanks for staying up tonight and speaking to us about how your experience as a radiologist and a successful interventionalist has shaped fracture care and what we can do better.
Thank you very much, Jens. It's great to be with you. And I'd like to talk with you, great to be with everyone, in fact, and I'd like to talk about some of the clinical care pathways. And the first comes with the diagnosis. And most of these diagnoses of vertebral fractures are not diagnosed. There's less than half of these. They're called compression deformities, compressed vertebrae. They should be called fractures, compression fractures. And not long ago, a multidisciplinary group worked on the RAND UCLA appropriateness methodology to develop clinical care pathways for treating vertebral compression fractures and the underlying disorder of vertebral compression fractures. So this is just an example of the level of granularity that was designed. And this is designed to produce clinical decisions at the level of each particular patient. So this is designed to treat patients with fractures. These are the 7 determining things that are likely to cause the patient to be recommended to be treated or not. All of these are statistically significant based on multidisciplinary input. And interesting, the greater the degree of clinical symptoms, the greater degree of radiologic deformity, with the greater the risk of being recommended, the greater the chance of being recommended for fracture, and duration of pain relief was the least of these. And what about the follow-up? So this is done at the level of the patient, and it's designed to get the patient treated for their underlying vertebral fracture, osteoporotic only. This particular section of the UCLA RAND was, but what about the follow-up? So follow-up recommended treatment of the underlying disorder, the underlying osteoporosis. And here's an example of our protocol. So these are examples of what we do in CPT codes. So after the vertebral compression fracture repair, we see them back. We do a DEXA scan. We do injection training because all of the anabolic agents are injectables. And we use by far and away anabolic agents as would be expected for a vertebral fragility fracture. Then a DEXA scan, then we send them out for home health training. This is billed out as a G0180. We see them again at 1 year, another DEXA scan monitoring the bone mineral density gains. And then we see them at year 2, another DEXA scan to put the final touches. And we typically use PTH analogs most commonly. So this is a 2-year follow-up. And then we recommend a follow-up medication and then send them back to their primary care physician after the recommendations and the workup are all complete. And so we have recommendations for the treatment of the underlying vertebral compression fracture when the patient comes in. And we also have recommendations for the underlying disorder of osteoporosis. But if we were to say one thing about both of these is that they're both under-recognized and under-treated. I mentioned too that if you look at the number of fractures that are missed, the Gelbach data says about half of these are missed or they're incompletely or inaccurately described, and less than 20% go on to being treated for their underlying osteoporosis. And this was a few years ago, and this is getting worse. So this is Solomon Dell data that essentially says 80% almost of these patients after a fracture of the wrist or hip will go untreated for their osteoporosis. And this is fairly well known, often quoted data by Dell and Solomon. This is the PSI data on hip fractures. There's other well-known papers that describe the hip fracture treatment of underlying disorder going from about 40% in 2002 to about less than 20% in 2011. This is even worse. And so we have about 10% of people that have their osteoporosis treated within 6 months after a hip fracture, down to 3.3% in 2015. And hip fracture is one of those that you can't really confuse with an osteoporotic or fragility fracture. Fall from a standing height, person breaks their hip, can't walk, foreshortened in internal rotation, confirmed by x-ray. There's not much doubt that this is a fragility fracture unless there's a lytic metastasis in the hip. And so this is something that is just, the ball is dropped in terms of follow-up treatment. And one of the reasons why, I think, is there's confusion over the diagnosis. So one particular commercial insurance, we have to get a DEXA scan. And in order to treat an osteoporotic vertebral compression fracture, it has to be a DEXA scan of -2.5 or less, which is a DEXA definition. Well, that's true, but that's the last one on the ACE criteria. That's number 4 down there. The first is a low trauma injury that produces a hip or spine fracture is by definition a defining event of osteoporosis. And so this is the first and the criteria listed commonly. This is taken from the Camacho et al. This is the ACE criteria. And so we have to understand that just clinical history can provide a defining event of a diagnosis for osteoporosis, as well as in the osteopenia range with a major fragility fracture or a FRAX score in the range of a high risk. And so if we look at the people that have a DEXA scan, 82% of these that have fragility fractures do not have DEXA scan scores of osteoporosis, or meaning -2.5 or less. And 2/3 of them have scores greater than -2.0. So the vast majority of these people that have fragility fractures do not have DEXA scan scores that indicate osteoporosis. And so here's articles, is brand new out of JBJS, and it studied the Pearl Diver database, 36,000 patients. So look at the secondary fracture rate. The secondary fracture rate with cementation, kyphoplasty, vertebroplasty was less than the secondary fracture rate of non-surgical management. So that's one misconception that unbelievably still exists, as you don't produce more fractures by treating somebody with cementing, whether it be vertebroplasty or kyphoplasty. The other very salient point is only 7.8% of the patients received osteoporosis meds after the vertebral compression fracture. And so you can cut the secondary fracture rate in half by treating them with osteoporosis medication, 10.1 as compared with 21.9, and you can reduce the subsequent vertebral compression fracture rate by 19%. So not only is the osteoporotic meds extremely important in reducing the secondary fracture rate, reducing it dramatically and significantly, but the vast majority of people, 82% of the people, did not receive medications. And so the medications we use, this is an example of an absolute relative risk. I'm just giving you abaloparatide as an example, 3.6 and 86% reduction of additional fractures. And this is dramatic reduction with PTH analogs. And you combine this with 70 milligrams of alendronate for 2 years, and you're getting spine increased bone mineral densities almost 14.5%, which is extremely high, and then almost 5.5, almost 6.5% per femoral neck and total hip. We do anabolic stacking. We do sequential anabolic therapy for some of our patients that are very osteoporotic, and the amount of bone mineral density you can gain from doing this is profound. I mean, it really makes them, puts them in the normal range in terms of the DEXA scan score after this. This is an example of 18 months of abaloparatide plus 1 year of romosozumab, 22.7% increase in BMD. This is another one, 2 years of abaloparatide followed by 1 year of romosozumab, 26.3%. And I've seen rates 30% or a little bit higher than that with a 2+1 sequential anabolic therapy, usually with a PTH analog followed by a sclerostin inhibitor. And so the future of this is going to be better ways of repairing fractures, better use of our existing medications, because our existing medications are pretty good. It's just we need to refine them, their use better, and the most importantly, we need to start using them. We can't make any headway when 92% of the people are not being treated for their underlying osteoporosis after an obvious vertebral compression fracture. And there's drug device combos on the way. And the most important thing is improving the rate of diagnosis and treatment will improve the clinical outcomes undoubtedly. So an existing clinical pathway exists for the treatment of vertebral fractures, and this should be known. It should also be known that existing clinical care pathway provides recommendations for osteoporosis treatment, but the optimization of the diagnosis and treatment of these protocols is absolutely necessary to improve the patient outcomes. Thank you very much. With that, I will turn it back over to Dr. Chapman.
Thank you, Doug. Great stuff. Again, just 2 highlight lectures in a row, and your passion is there. Yes, our birthday boy, Alan, is applauding, and so does everybody else who's listened to this. 2 questions. So first of all, radiologically, a lot of people say, oh, DEXA scan, hard to get, this or that. As a radiologist, how responsive are DEXA scans? You showed some stuff that I've not seen in this dimension before with the success of stacked medications. But where is, and I rephrase the question I asked to Dr. Cates before, how responsive are modern CT, ROI, opportunistic CT calculations? Are they perhaps more responsive as an ad hoc measure for A, risk stratification, and B, also monitoring of successive therapies?
Yes, absolutely. They're better. You know, I think most of us on this are familiar with this. You can measure 3-dimensional osteoporosis measurements, bone mineral density measurements with ultrasound, MRI, CT, and these are done better than they are with the 2-dimensional DEXA scanning scores. It just so happens that the WHO recommendations and most of the existing treatment recommendations are based off of DEXA scan scores. So I don't hesitate at all. There's opportunistic MRI, there's opportunistic CT, and there's really good standards of measurement, and most importantly, the ability to follow these along and to get increases or decreases, changes in BMD is really very sensitive to small changes. And so these are preferable. I think it will just take a while before we come to rely on these and have recommendations that are clinically based.
Our birthday boy has his hand up. Alan, fire away.
Thanks. Great talk, Dr. Bill. That's fantastic. This is wonderful. I'm really excited to hear about all these things. But I have a question about other imaging modalities. What about quantitative ultrasound, something that would be portable, easy, cheap? You know, you could just take it around in a van practically and, you know, and scan people's feet. Is that, would that give valid data, or would that be reasonable?
Well, Dr. Greenwald, stop with your logic and reason. I mean, that's absolutely exactly correct. I mean, this is probably the single modality that would be accurate, portable, precedented, and very easy to use. And the data for this, in terms of transmission of sound through bone, it has standards already that exist for determination of bone density. And so all we need is just to kind of employ this clinically to do that. And it's very reproducible. And as you said, it's very portable. So this is probably the biggest, brightest spot in the area. So not everybody can buy a new CT scanner or an MRI But the ultrasounds are very cheap, and it comes with a reference standard that's been around for 15 years. So yeah, I really like that idea. It just will take some practitioners to popularize this.
So Dr. Anderson, in a second, Yev Frevert is one of our former fellows. He's a brilliant young neurosurgeon in Houston, and I'm so glad that neurosurgical colleagues are now getting involved in osteoporosis care. Yev has done some work and some research work on opportunistic CTs and predicting fractures after surgery. Just quickly, without going to lecture, can you give us an outline of what your findings were, how responsive CTs are, how reliable they are? Is this a venue that we've just overlooked?
Yeah, absolutely. And I actually, at a previous WSOA, I gave a slightly more detailed talk. The general idea is that there's a substantial amount of literature already validating opportunistic ROI measurements in CTs, at least in spine surgery, as being potentially predictive of hardware failure and subsequent fractures. The angle that I took is actually to trend that over time. Many of the patients that we're looking at in the spine space, and certainly in other orthopedic areas, I'm sure this also applies. You have multiple scans that you can follow, so that gives you a potential other factor that you can trend, specifically what the bone density is doing over time. And logistically, that's potentially much easier than getting many DEXA scans over the course of years. So that's kind of what we're looking at right now, and I think there's a lot of opportunity for automation as well, but that's to come in the future.
And one more comment, Dr. Anderson, then we'll want to proceed with Dr. Schonert. Paul, thanks for joining us. Thank you, Yev. Paul, you had your hand raised.
I was muted. Yeah, just to put a little warning in about the use of these other modalities, and believe me, nobody has advocated opportunistic CT more than I have, is that the results you get are not been validated in fracture trials. And so insurance companies in general do not accept like ultrasound at all. They may accept, if you browbeat them enough, opportunistic CT using thresholds such as 110 for a lumbar spine Hounsfield unit. We took us many times to argue with them before they finally believed us. So that's one of the limitations of not using DEXA, because the darn insurance companies want to see a DEXA, even though, as Doug said, you don't need a DEXA to diagnose osteoporosis if this patient's just sustained their 5th fragility fracture, no matter what their bone mineral density is.
Great. Okay. Let's look at clinical implementation. So Dr. Schonert is one of the senior surgeons of the Pro-Alliance surgeon group here in the larger Puget Sound area. And he's managed to do something, as he's presented previously, and that's make a huge difference in terms of reimbursement for osteoporosis care with early vertebroplasties. He's shown basically that these are very efficient. He's gathered some new data together, and we're excited to feature this here for the first time. Neil, thanks for joining us, and thanks for spearheading this program tonight.
Oh yeah, Jens, thank you, and a shout out to Alan. Happy birthday, Alan, and a thank you to Steve and Doug and Paul for participating. If I could, I just got out of the OR, so I'm not running my slides, but let's go to the next slide, because I'm going to show a clinical application. As Paul has highlighted, the problem is rather dramatic. The amount of neglect is rather dramatic, and the opportunity for change is equally dramatic. And what I'm going to be talking about is orthopedic osteoporosis care pathway in the Pro-Alliance surgeons system. We have about 3,800 of these fragility fractures year to date. We counted them last week. And that counted only those over 65 and fractures of the spine, of the hip, the shoulder, and the wrist. So the number of fragility fractures we see in our clinic is actually greater than this. And to follow Steve and Paul's recommendations for 50 and older would expand this. But I'm going to talk about how to implement something that you haven't done before. So in my clinic, there's 800 fragility fractures, and we're going to pilot these. Next slide, please. The thing that we're going to look at, these are the elements of a high-functioning post-fracture care program. Next slide. They align to the fracture liaison metrics that Steve and Paul have published extensively on. Because these folks already have fractures, they already qualify for anabolic treatment. And because they're having a new initiation of a new therapy, DEXA scan, FRAX score, opportunistic CT labs, all can be started once the patient is diagnosed with the fracture. The payer landscape actually influences this greatly. So in the fee-for-service with supplement, it's distinctly likely the patient will have either no copay or $100 copay until they reach a maximum of $500. So by the 5th month of the year, as each year turns over, they'll be back on no copay for these medications. And the Med Advantage programs do not do so. So in those circumstances, patients often have to pay $3,000 to $5,000 per year. And for an elderly woman on a fixed income, that's not achievable. So this results in a natural experiment. Next slide, please. And that's what we plan to do, is to look at this from the perspective of orthopedics owning the fragility fracture, running an orthopedic playbook. And thank you very much, Doug and Steve, for filling out the details of what this playbook looks like. Not only from the standpoint of the staffing that Steve ran through, but also the awareness that stacking these injectable medications can be particularly beneficial. We're also looking to automate it so that the coding aspects, authorization aspects, the PRO recording, baseline and PRO recording occurs in an automated fashion and doesn't require FTE. And that we can track digitally compliance and secondary fracture. Next slide, please. This is what it looks like. This is a variation of our osteoporosis and sacroplasty registry data tools. The vertebral compression fracture registry, which Doug and I and Paul published on. It's the largest in the world. The sacroplasty registry, which is just being published now. Use these data processes and data management tools because it is, as Steve mentioned, critically important to enroll in registry, because that's how you influence payers. Doug and I testified before Medicare Administrative Contractors in 2020 and changed authorization based on healthcare utilization data that came from this registry tool that you're looking at right now. Next slide. So I'm going to conclude and thank everyone, particularly Steve and Doug, who are up at the wee small late at night, and Alan, thank you for being here on your birthday. I've got that's all I have to add for tonight. Thank you.
Thank you, Neil. Great job, and very nice, very brief overview. So the quick question is, hospitals, at least in our state, have not been interested in really taking a role in this. We've tried to approach healthcare systems outside of Kaiser with some restrictions, have similarly not really played ball. How does your physician group respond to this? What angles can you envision where we can kind of make greater inroads in the future?
So the great thing about private practice is we're very efficient at figuring out how to make this marginally profitable enterprise more profitable. We're compelled by that desire. So we see efficiencies evolving in this rather rapidly. And we also see it as an excellent marketing tool to show the community, and Steve rightly touched on that. So I think it is not only something, a service you provide your community, but it can enhance your practices dramatically, particularly with the daughters and granddaughters, because they have a full awareness of what you're doing for their mother and grandmother. And then lastly, it is going to be, I'm going to follow Steve's lead on that A3 notion of keep it simple, present it to the health systems. I've already begun that work so that they can see that this is in their best interest and impacts their bottom line. Thank you,
Well
Jens.
said. Great. So we'll close the formal lectures, and then hopefully we'll have time for vigorous discussions with my mentor, my faculty educator, Dr. Paul Anderson, who has gone on to the University of Wisconsin, has made a national, international name for himself by being spearhead, together with Dr. Kate. So we have two icons here of the Own the Bone initiative. And I just wanted to, we wanted to hear from him how this Own the Bone system actually has worked, and how we can use the Own the Bone tools to get grassroots involvement on not just radiologists, ER doctors, primary care physicians, but also healthcare politicians, levels 2 state initiatives like what Dr. Greenwald has spearheaded here. So thanks for being here tonight, Paul.
No, thank you, Jens, and shout out to Alan. Happy birthday to you. It's always great to be back talking to the Washington State Orthopedic Association. And I'm just going to review this quality improvement program that we call Own the Bone. This is a national fragility fracture quality improvement program. It was actually started by Mark Swinkowski, who used to be the chief of ortho at Harborview and trained at UW. Own the Bone was launched clinically in 2009, and it provides a toolkit to help people initiate bone health management after fragility fracture. Now it is also helping to do bone health optimization for elective surgery. One of the key components, we've talked about this, Neil has talked about this a lot, is a registry. And we use a REDCap cloud database, and the registry is a lot of work because people have to enter the data, but it's very important because it gives you the metrics for which you can compare yourself to what you used to do or what other systems are doing. The REDCap is really nice cloud because it can be done anywhere, and all you need is an internet connection. So far, about 75,000 people have been enrolled in the 12 years that the Own the Bone program has done. The follow-up is not nearly as robust as one would like, but we are getting a good idea of who we're treating and how they are being initially managed. And there are a lot of papers using this database out there. One of the important things, and I suggest anybody starting a quality improvement program, you have to set out what metrics you're going to collect and then measure them to see if you're meeting your benchmarks. And this is from about a year ago of the overall program meeting the benchmarks that Own the Bone has set out. And they're all about 90% or more. The only one that's the lower than that significantly is the treatment recommendations, where only about 75% of people are getting recommended with medication. And that's very appropriate because not everybody with a fragility fracture is a candidate for medical treatment, but the majority are. And this shows that the program, if you enroll in Own the Bone and follow the recommendations that we provide, you will have high compliance with the basic benchmarks. These benchmarks have been adopted by a lot of other organizations to benchmark themselves. So I really wanted to go over some of the challenges and the keys to success. Again, you have to realize this is a quality improvement program. And as several other people have mentioned, you want to identify the problem with numbers. And so you need to go find out how many fractures you're treating, and are these people getting secondary fracture prevention? You can look at root causes for why this is happening. Most of the time, it's because the orthopedic surgeons think the primary care is going to take it, and the primary care doesn't have any time, and there's insufficient bone health doctors. So this, to correct this, is really need to establish a fracture liaison service. And frankly, the fracture liaison service is much more efficient if it's housed within an orthopedic team. Then you need to monitor the results, find out how many people are compliant with your recommendations, are they getting treatment, and ultimately, are you getting reduction of fracture risk? This is my own data. In 2015, we assessed how patients were being treated. That's the blue line after a fragility fracture of hip, wrist, and spine. And it was about 20% got a vitamin D levels, 15% got DEXA. And at the time, we couldn't figure out how many actually got any treatment, but it was low. We then, the green line is what happens now if that patient is one of our primary care doctor's patients. 90% compliance with all of these metrics, and 75% are getting treatment. The gold ones are patients that we treated for their fracture, but they were too far away to come back, and we had to communicate with their primary care doctors. We pushed it, improved it a little bit, but not very much. So it just shows you the power where you have to take control of the bone health. Otherwise, it won't happen. Some of the early success is, as Neil just said, keep it simple, use existing staff structure, like existing NPs and PAs, and train them so they can do this part-time. Piggyback off of other initiatives. For instance, a geriatric hip fracture program is the typical one. And always measure what you do as you would in any quality improvement program. Plan for long-term success. That means, as Steve said, you really need the right people. You need a champion, and this has to be a physician who can advocate with administration. For Own the Bone, most often it's an orthopedic surgeon, does not have to be, as a number of our programs have had bone health doctors do this. You have to stay committed to this cause. And then you also need the NP or PA or bone doctor who's really dedicated to make the program and can operate the program. But you also have to allow time for that person to build the program, interact with the referring docs, and this has to be justified on the return of investment. Again, the leader is best for this kind of program if it's an orthopedic surgeon, although it doesn't have to be. The advanced practice provider provides most of the care, and again, it's best within the orthopedic team, because the biggest problem in secondary fracture is lack of access. And if you aren't able to provide timely treatment, patient's not going to get it. The one mistake we had is we didn't have an RN assigned to help our NP when we started our program. But there is a role for an RN who's not going to prescribe medicine, but it's going to do a lot of the education, help coordinate the care, do the injections, run down the labs, and spend a lot of time so that the PA can actually see more, or NP can see more patients. Some of the challenges are to maintain the leaderships and champions. Programs that Own the Bone that have quit have largely quit because the leader either retired or left, or several hospitals got bought up and 2 or 3 programs now became one. But the other one is funding and economic viability. As Steve laid out, if you have the right person, the right team together, in a year or 2, this can be at least revenue neutral. And that's not even considering the added on advantages for infusions and labs and physical therapy. There is a lot of non-reimbursed care, however, and that's why we're trying to offload it more onto the RN than the NP, which is more cost effective. You have to figure out how to build these referrals, but once you start, the dam will burst and you will be flooded with them. And the other thing I would urge you to think about is that osteoporosis is a chronic disease, and now it's fitting it within an orthopedic service that the orthopedic team is not really used to dealing with chronic diseases as well as a primary care team. So I encourage orthopedics to take ownership. You have to assure that patients are getting some kind of secondary fracture, best done with a FLS model. And I would urge you all to become champions. Start small, grow organically, and join like groups in your region or in the country, such as Own the Bone. Thank you very much.
Great stuff. Paul, Stephen, Doug, and of course, congratulations to Neil. You guys have changed the game. You've provided us with the know-how and the equipment. I still struggle with how to get this to the ground. As a spine surgeon, I know this goes to Doug and Stephen maybe primarily. Does it help putting into radiology reports high suspicion of osteoporosis, putting it down? Stephen said it in his initial lecture, tell the patient. So should our radiologists, when they have a suspicion or when they do a quantitative CT, put that in there before we have a DEXA scan? How can we get the message to the patients to try to enable them?
Yeah, absolutely. I think that's the first step, is to understand the thresholds that give rise to commonly observed osteoporosis scores for DEXA, for CT, and for anything that we use, any type of three-dimensional modality. And the second step is for the radiologist to put that in the report. And I think there's enough evidence. We don't necessarily need recommendations. We don't necessarily need insurance recognition of thresholds for osteoporosis. But what we do need is good clinical acumen. And what we do need is something for our clinicians, our colleagues, upon which to base their treatment. So I think it would be a very good start.
Stephen and then Paul. Yeah, Stephen and Paul. DEXA scans. A question from our chat box was, how often is DEXA scan actually valuable as a routine screening tool for postmenopausal women? And how often is it actually just used as a post hoc validation that this patient has osteoporosis and more or less is secondary in importance then? Stephen, maybe first and then Paul.
As a screening tool, I think it's good. For post-fracture care, it's most useful to follow your progress with treatment. I don't think it's a great screening tool if they have a fragility fracture. They have the diagnosis. You just want a baseline to see, are you making progress in the right direction for your treatment.
And then every year or every 2 year, what's the interval? You said something like every other year. Is that what you recommend?
Well, it's generally paid for every other year. If you want to follow something more closely, it's an inexpensive test. So if the patient can afford it, it's, more frequently is fine. Their payer usually pays for it every other year.
I think that's for monitoring. I think for screening, you probably don't need it that frequent unless the patient has certain diseases or takes medications. So I wouldn't say you have to do preventative screening that often, but certainly monitoring every couple of years is very reasonable. And for an anabolic, it's actually the first 12 months you'd want to recheck bone mineral density.
Our former president, Dr. Ryan.
I was going to say the important point, as Doug mentioned, is that you do not need a DEXA scan to make a diagnosis of osteoporosis. And that's where radiologists can really help us, because so many people have occult spine fractures on all this cross-sectional imaging and that people are getting, and they're not being even noticed that they're fractured. I mean, we had in our hospital, where I have one of the world's experts in screening for osteoporosis by CAT scan, we'd have burst fractures that weren't even mentioned on people. And so getting the radiologist to mention fractures is really important. And also for the orthopedic surgeons, if a patient has a occult spine fracture that you identify, that patient is at huge risk for elective surgical complications, such as a periprosthetic fracture or a failure of a long spine fusion of a Chapman special.
Got it. Dr. Wyachik, you had your hand raised. Did you want to say something, Greg? Nick? Let's go to Dr. Mayo. Dr. Mayo, so you're an experienced spine surgeon, experienced hip and pelvis surgeon. What is missing in your practice right now so that you can implement the great know-how, the great knowledge that AOA has put out there through the combined wisdom of Drs. Cates and Anderson? What's missing right now in your practice?
Well, I'm in a bit of a handicap because my patient population is several decades younger than the at-risk group here. But what I do see posterior pelvic ring insufficiency fractures. And I think that I guess what I've always wanted to be able to do is to take my subjective impression of osteopenia on plain films, because everybody gets plain films, and figure out a way when that should be followed up with a DEXA or some other way of assessing risk elsewhere. So, Paul, were you going to say something?
Yeah, I would say for you, Keith, the thing I would find very valuable is the door classification of the proximal femur geometry, or you can measure what's called the cortical index, which is the sum of the thickness of the cortices divided by the diameter at a point 10 centimeters below the lesser trochanter, because those strongly correlate with osteoporosis. If you have a door C, which is that thin cortices, capacious canal where you can drop a 20 millimeter rod down it, that patient has osteoporosis. Now, in the people who are undergoing dysplasia operations and things, it's probably not as important, but certainly you get over the age of 50, you have to start worrying about that. The one thing I have seen in our institution in the younger patients with hip pathology are now postoperative stress fractures of the pelvis after PAOs and things. And we're finding low Hounsfield units in those patients. So I think there would be useful screening in those, potentially in some of those patients.
Oh, I'd be interested. I'll call you about that because I've never seen it. I guess the other thing that sort of displays my ignorance is and prejudice is that, and Steve, you can probably talk to this with your trauma background as well, is that I just have this inherent bias against non-anabolic agents, because what we see as far as the proximal femur subtrunk fractures, we see them in the tibia as well, and so I mean my default drug in the patients that I see has always been teriparatide, and there are some people that are excluded by virtue of contraindications. I don't know that much about denosumab, but it's probably a bit better. But the bisphosphonates as a group, particularly used long term. Again, I'm only seeing the numerator, but the numerator is pretty significant. So.
Yeah, I favor anabolic agents if I can get a good reason to use them and get them approved, or the patient can afford them. I definitely would prefer an anabolic agent, especially in a post-fracture setting, depending on all the circumstances. Certainly, you get that beneficial effect on the fracture healing, especially if it's started early. We have used romosozumab. I'm not sure that it enhances fracture healing, but it definitely builds a lot of bone mass. The anti-resorptive drugs are good in the patients who come back for sort of, I had a fracture, I have this, I don't know what to do, or I was told to come see you guys and it wasn't a recent fracture. That patient, an anti-resorptive is fine. The anti-resorptive we will go for after completing a course of anabolic treatment as well to maintain the gains. So that's when we're likely using them. The other person is the patient who's in a nursing home where they're not going to get the frequent injections of the parenteral drug, and you want more of a fire and forget type of treatment, that we will give them the IV bisphosphonate once a year, but we'll wait 6 to 12 weeks after the fracture before they get that. because otherwise it all ends up at the fracture site.
One thing about pelvic insufficiency fractures is there is a randomized controlled trial that showed earlier return to function and better pain relief with an anabolic. In this case, it was teriparatide, but probably any of them would give you that effect. Although there was a comparable study done in the United States that showed no effect. But I think those particular patients, I like to get on an anabolic as soon as I can.
So Stephen, one of the questions, it's a dual question. Where can we go with virtual clinics? I addressed it a little bit beforehand, but Dr. Greg May, one of our great colleagues in Aberdeen, Washington, says, I'll get whatever labs you want me to do. Is there any way to have a virtual fracture liaison service in larger centers that I can work with, that can help me manage the patients? I'll do whatever they need to do. So where are we? Where are you in your region? And maybe Doug can take it from the Oklahoma standpoint. Both of you have made a huge impact, but how can we kind of spread this around into rural areas and create one virtual center, provided state laws allow that?
Yeah, we do virtual visits during the day, interspersed with in-person visits. And then I think our APP's got a virtual clinic where it's just virtual visits only. They're definitely, this is a good use of them. There's not a big exam for this, which makes it nice. A lot of it's history and reviewing lab work and talking to and communicating with the patient. So if the patient has the ability to do a video visit, I think, that requires a little bit of technical know-how on the part of the patient. They have to be able to use the computer and click the link and stuff. So assuming that they can do that, some of them are quite elderly. I think it's great. You could potentially use it in a nursing home setting as well, where they don't want to bring them to the doctor. We all know that they in a nursing home, they bring 3 or 4 patients a day to the doctor, and they're going to typically bring the patients with higher acuity problems than osteoporosis. So I think there's a lot of use in this setting. They're great for follow-up visits. Still can bill for them, which is nice, and they're pretty efficient. So as long as the patient logs on, some of the patients are technically challenged, or in the rural settings, at least in Virginia, there's not real good internet. I know that sounds kind of funny, but rural Virginia does not have good internet. I'm out in the country here, and I'm shocked that my internet hasn't cut out yet, but it seems to be working tonight.
Yeah, I agree. Half of our visits are remote or telemedicine now, and actually put in a PCORI grant for creating a statewide centralized system where anybody could be referred to us, and we do everything by telemedicine. I didn't get funded, so I couldn't do it, but I could foresee, Jens, that a bone health center be created in the state of Washington, where any orthopedist could refer that patient and they could just take over the care. It requires a tremendous amount of coordination of care because you have to work with primary care doctors, labs. Big problem is DEXA. DEXA quality varies a lot. It's not like CAT scan or MRI. And so you have to find out where you can trust the DEXA scans. But for a post-fracture care, I think having a central hub where any orthopedics in the Washington State Orthopedic Association can refer a patient to them and they take care would be an outstanding model. The problem is, how do you get that funded to get off the ground? But that is very much my vision of how to deliver this care. Because what we're doing now is not working very well.
Yeah, that's exactly what we're trying to do as well, Paul, is we're trying to get a central area that we can establish a referral base to. And we do a lot of we believe in the treatment sequence matters. So we do almost all anabolics first, followed by antiresorptives. And we really like the PTH analogs, both those medications first. We anabolic stack for our severes. We follow it up with a bisphosphonate based on some of the recent work published by the aptly named Henry Bone. And this is something that requires a lot of follow-up, and the telehealth visits have been a huge benefit for us to be able to monitor people. And we get a lot of referrals from rural. I practice in Oklahoma City, and it's a big state, not very populated. And it's very, very helpful to have, especially the elderly patients, have a telehealth visit. It's helpful to have these telehealth visits reimbursed, which is one of the positives of COVID, and to be able to evolve this to a central repository referral area that we can take and see patients and provide just a little bit of expertise and expand this by way of economy of scale. I think that's a perfect scenario.
Al, so you may not have to put your van out on the road. You may have to be able to, or you may be able to do it just from the comfort of the aquarium podium here.
Yeah, no, I think I understand all the incredible effort that the panelists have put into this process, but to make this work, I think you do have to go out in a van with an ultrasound device and like Cinderella, test everybody's heel who's over 65 and find the ones that are osteoporotic and start treating them. That's how it's going to get done, I think.
So one practical question for Steve, and then I want to let everybody go because it is late on the East Coast, and Steve insists as always, and so is Doug, a giant. How kind of efficient are you now with your program to get expensive medications funded? So this is always kind of a break point. We have a number of letters, but I'm sure they're amateurs compared to what you have. What appeals letter, what kind of automated response systems do you have in place for the inevitable denials of so many insurers?
Yeah, I think the key thing is using the right code initially. So if you just put it as like senile osteoporosis, it's not going to get paid for. You have to label it as pathologic fracture caused by osteoporosis of the sacrum, or pathologic fracture caused by osteoporosis of the lumbar vertebra. You have to code it that way. There is an ICD-10 code for it. Find it in Epic or whatever you're using. Find the code that pertains, and that usually will get them to pay for it. You may have to list, as Paul said, you may have to list a DEXA scan value, and it helps to list that they have prior fractures. Most of the time, we do not have to do peer-to-peer reviews for these, but occasionally we do. And, putting a comprehensive note in initially, and this is where the APPs do a good job. We build a nice templated note for our APP, and she fills it in. And you send the note, you send the pre-approval form. We use whatever form the payer insists we use, send it in, and they usually been paying for it. So there's a few of the medicines that they pay for pretty easily. Teriparatide, they don't like to pay for very easily, but they usually will pay for the romosozumab or the denosumab pretty easily. That, they're clinic administered, so the patient's got to come in and get the subcutaneous injections. And, they'll come in, they'll talk to me for a couple minutes about their fracture, their non-union or whatever it is, sacral fracture, whatever we fixed on them. And then they're going to get their shots, and they, come back in either 6 months or 1 month, depending on what drug it is. And, we follow them up, we talk to them, and I'll usually, if it's a fracture that we operated on, I'll usually talk to them, or if it's a patient who's a high profile patient who's complaining. Most of them are these sacral insufficiency fractures that drive them crazy. And, they call incessantly till they heal. When they stop calling you, that it's healed.
So Neil, talk to us about the sacroplasty registry, and then we have to really come to a close. So there are certain companies, no names mentioned, that really promote these very large titanium screws with whatever 3D printing, etc. In your sacroplasty registry, is there any trend apparent in terms of putting these super high-powered screws in relative to sacroplasties, or using and relying on pharmacology? What is your current gestalt of this emerging field?
So the registry that both Doug and I participated in and are publishing centers around cement augmentation, similar to the vertebral compression fracture registry, only extending it down into the pelvis. So there are not, they are interventional treatments. They are not operative treatments from the formal sense of instrumented fusion, or ORIF. So there's cement augmentation methodologies.
Great. Okay, so must come to a close.